Okay, we will start in another minute. Well, thank you all for joining us today on this important webinar that's focused on COVID-19 and older New Yorkers, when we will be hearing about the findings from the Silver 2 survey. I'm Wafa El-Sadr, and I'm the director of ICAP, and I'm also a professor of epidemiology and medicine at Columbia University. And it gives me great pleasure to welcome you all today, welcome our speaker, as well as our esteemed panelists. As all of you are well aware, COVID-19 pandemic has severely affected older individuals, both in New York City, in this country, and around the world. And although we have at our fingertips now, we have availability of COVID-19 vaccines that have been shown to substantially decrease the risk of severe illness and mortality, we still know that older individuals, those who are 65 years and older, are still at higher risk for some of these complications when we compare them to younger individuals. And we know at the same time that while older adults are encouraged to get vaccinated and of course to seek booster doses as soon as they are available, we also know that they are often advised to limit their social contact because of their higher risk, leaving many of them to experience isolation as well as to limit the social supports that they are receiving. Now, in order to better understand the challenges of the COVID-19 pandemic and older adults living at home, particularly in New York City, we conducted the SARS-CoV-2 impact on lives and views of elderly residents, what's called in brief, the Silver study. This included 2 rounds of phone surveys among a cohort of New Yorkers aged 70 years of age or older. Today, we will be hearing the findings of the second round of the survey, which yielded important data and findings about the social determinants of health, mental health, physical well-being of this group of New Yorkers during the second year of the COVID-19 pandemic. Now, it gives me great pleasure to introduce our speaker for today, and that's Dr. Abigail Greenleaf, Aba Greenleaf. And Dr. Greenleaf is a public health demographer who is a technical specialist at ICAP and assistant professor at the Columbia and Mailman School of Public Health. Aba has previously worked on phone surveys, both in the United States, as well as in several countries around the world, low and middle income countries and around the world. And she also led the Silver study, which will be presented today. So I'll hand it over to you, Dr. Greenleaf, to share with us the key findings from Silver 2.
Thank you, Wafa, and thanks everyone for joining today. I'm really looking forward to sharing the results from the second round of data collection. Great, so at least 1 in 4 New York City residents have been infected to date with SARS-CoV-2, the virus that causes COVID-19. In particular, older adults, as Wafa mentioned, were ill-affected by the COVID-19 pandemic. And New Yorkers over the age of 60 are the city's fastest growing population. We're all well aware of the increased risk of death, as highlighted on the slide, when comparing older adults to younger counterparts. But not only has the mortality of COVID-19 been severe for older adults, but so has the morbidity, the impact on their well-being. Previous studies have shown that among adults age 60 and older who live at home, depression symptoms were more than 3 times as common during COVID-19 than they were before the pandemic. And people who had less access to social support, lower income, and were exposed to more stressors, such as financial problems, reported depressive symptoms more often. While older adults have great strengths and resilience, they have been particularly vulnerable during this era of COVID-19. So, the work to study older adults here at ICAP started almost 2.5 years ago. A first baseline round of data collection was conducted December 2020 to March 2021, resulting in valuable insights on the well-being of older adults. Given the continuing stress of the pandemic, we continued a second round of data collection 1 year later to assess how older adults were faring under this continued risk. So beyond the overall aim of describing the well-being of older adults at home, there were 7 additional research aims for this second round of data collection. 11% of older New Yorkers are Asian, but only 3% of our study sample in round 1 was. So given the disproportionate impact of COVID-19 on Asian New Yorkers, it was imperative to have them represented in this cohort study. So to complement the existing silver cohort, we conducted a targeted enrollment of Asian older adults, and I'll tell you how we did this shortly. Given the waves of COVID-19 and related social isolating and less restrictive measures, we wanted to continue to understand participants' COVID-19 knowledge, beliefs, and actions so we could contextualize their behavior, such as whether people were accessing older adult centers again and why, and then well-being such as mental health and loneliness. Going to point 4 on the slide, of course, the importance of vaccines cannot be understated in preventing COVID-19 mortality. So we wanted to know more about vaccine uptake and influenza uptake as well. We reviewed the literature and discussed with advisory group members, deciding to include questions that address the evolving challenges of the pandemic. We've really seen that compared to the first round of data collection, we kept many questions, but we added questions in that really reflected the current state of the pandemic. We're of course interested in finding out about social supports and in particular telehealth, and then understanding re-engagement with society. The 7th point on the slide would help us have insight into how and when older adults are willing to re-engage with services provided by our colleagues at Department of Aging and other services. Finally, the impact of mental health is not to be understated in this population. And this time we took a look at resilience. So how did we conduct this study? The follow-up of round 1 participants and new enrollment for older Asian participants took place simultaneously from February to March 2020. Starting on the left of the slide, we called 602 round 1 participants who agreed to follow up. We called them up to 10 times. We really tried to get a hold of as many as we could. The eligibility criteria as listed on the slide is the same as round 1. Moving to the recruitment of Asian older adults. So the general recruitment that we conducted in round 1 didn't yield enough Asian older adults, so we had to take a different approach. We took a much more targeted approach this time. So we, in specific neighborhoods that had high density of Asian New Yorkers, we linked phone numbers to public records to identify the age of the person associated with the phone number, and also flagged the phone number if the surname was associated with a number was an Asian surname. So that's how we chose our sample frame of phone numbers. If someone picked up the phone call, once we confirmed age, we asked the participant to self-identify as Asian or another race. If they were Asian and consented to the survey, they were enrolled. And again, as a reminder, data collection took place February to March 2022, which is right at the end of the holiday Omicron peak. So before sharing results, I'd like to describe the participants of our study. I will first share characteristics of the round 1 cohort that participated in round 2, and then I'll share the characteristics of our new Asian older adult sample. Of those who agreed to follow up from round 1, 297 or 53% completed round 2. We were glad to see that attrition did not differ by race, ethnicity, age, income, or borough. And of course, all our results were weighted to account for survey design, eligibility, non-response rates, and post-stratification. So as seen on the slide, 61% of survey participants were women, 39% men, 62% of the adults were 70 to 79, and fewer, 38% were over age 80. 45% were married, 65% not currently or never married. Not shown on the slide, but noteworthy, 93% of participants were heterosexual and 7% were gay, lesbian, bisexual, or another sexual orientation. Just over a quarter had immigrated to the United States. This reflects the diversity of New York City, but I will note is less than round 1. In round 1, half of our sample was born outside of the US. The majority of respondents lived in Manhattan, Queens, or Brooklyn, and we had 16% in the Bronx and 8% in Staten Island. 41% of our participants were white, 19% Black, and 19% Latinx, 23% Black and 19% Latinx and 17% another race or ethnicity. What do we mean by that? Anyone who was not white, Black, or Latinx were added to the latter group. These two questions were new to the second round of data collection, have proven to be quite useful. So we asked on the left, are your day-to-day activities limited because of a health problem or disability which has lasted or is expected to last at least 12 months? Over half noted no limitations, while 19% indicated that activity was limited a lot and 27% said activity was limited a little. We also asked, how often do you socialize with friends or family outside your home? 32% of participants had not socialized outside their home in the past week. 26% had socialized out of the side of the home on 1 to 2 days, 36% 3 to 4 days, and 6% on 5 or more days in the past week. Now we turn to the newly enrolled cohort of Asian older adults. We enrolled 64 Asian participants for an APOR response rate of almost 3%. And we are glad to see the sample was ethnically diverse. Asian Indians comprised 33% of the sample, Chinese, New Yorkers, 33%, and so on. Among these new Asian survey participants, 45% were women and 55% were men. The median age was 76 and 72% of adults were 70 to 79 and 28% were over age 80. The cohort is highly educated with 88% having a college degree or higher. So let's move to our substantive results. Given the increased access to home tests, particularly on the holidays, again, our study took place right after the holiday Omicron wave, we wanted to know where and how many adults were testing for COVID-19. So among the 20% of participants who reported testing for COVID in the past year, 15% had tested at home and 77% had tested at a pharmacy or testing center, and 8% had tested at both locations. Interestingly, when we look at home testing by race and ethnicity, we see 3 times as many white participants tested at home compared to other race and ethnicities. And of course, the next question is, what were the results of these COVID tests? 14% of participants had ever tested positive for COVID-19, with 30% of Latinx participants ever testing positive, compared to 22% of Asian participants, 11% of white and Black participants. We move to vaccination, where we find that overall 86% of participants were fully vaccinated against COVID-19, and among the fully vaccinated, so among that 86% had received an additional booster. Now let's look at vaccination rates by race and ethnicity. Asian participants were most vaccinated at 97%, followed by 92% of white participants. Only 72% of those of another race were vaccinated. 91% of fully vaccinated white participants had the booster, 90% of Asian participants, and 96% of those of another race. Finding out why these gaps exist between those who are fully vaccinated and the booster would be interesting to probe into in future rounds. So here we look at change in vaccination rate over time. So between round 1, which again, as a reminder, ended in March 2021, and round 2, which took place a year later, there was an overall 28 percentage point increase in COVID vaccination. All races and ethnicities showed an increased vaccination uptake. The greatest increase was among Black participants, with a 47 percentage point increase, resulting in 88% of Black participants being fully vaccinated. The smallest increase, with 14 percentage points, was among participants of another race. So this last slide of the section is about the flu vaccine. 2/3 had received the vaccine, 21% were planning to receive the vaccine, and 21% did not plan to receive the influenza vaccine. Interestingly, among those who had gotten the flu vaccine, 95% were fully vaccinated against COVID. And when you look at the inverse, it's slightly less. Among those who had received the COVID vaccine, 67% had also received the flu vaccine. So we'll now move to internet and technology. Round one results were really interesting. So we kept a couple of questions the same as round one so we could compare change over time. But we also added some additional questions where we wanted to find out more. So access to technology did not change between round one and round two of the survey. On the right side of the slide, you see that 78% of older adults had some type of technology, whether a smartphone, computer, or tablet. However, access differed by age, with the younger cohort, those 70 to 79, being more connected, 82% of them, compared to only 74% of those 80 and older having technology in the home. Asian older adults had more Asian adults had devices in the home than other races and ethnicities. We're interested to find technology access and experience differed by the binary genders. More men than women have computers in the home, starting at the top of our graphic, but fewer men have no technology devices at all. A minimal percent of both genders improved their technology skills since pandemic start, but more women than men thought their skills had decreased. Fewer women than men were comfortable accessing the internet and able to gain such skills. However, interestingly, women use the internet for texting, emailing, and messaging at the same frequency as men. So ultimately, this access and ease gap that we see between men and women doesn't affect women's use for technology for socializing. So I'd like to say a little bit more about social media use. Half of participants were active user, accessing social media once a day. However, we see differences by age group, with fewer adults 80 and older accessing social media daily compared to a third of those 70 to 79 accessing daily. So these telehealth results are some of the results I'm most excited to share. We, starting broadly, 72% had not had a telehealth appointment in the past 3 months with a provider, while 28% had a visit. This is compared to 44% overall in the first round. So there's a decrease in telehealth use. So I want to speak a little bit more about round one, as it really informed our round two questions. In round one, we found that compared to white participants, Black and Latinx participants had twofold higher telehealth usage, and those of another race had 3.5-fold higher telehealth usage compared to white participants. In other words, Black, Latinx, and those of another race were more likely to use telehealth than white older New Yorkers. We looked many different ways and couldn't fully deduce why these differences existed. So we were very glad to add some questions to round two to tease out the motivations to use telehealth and why these differences around race existed. So as you can see on the slide, this higher use by race did not, and ethnicity did not persist in round two. Specifically, telehealth use decreased between round one and round two by 26 percentage points among Black participants and 23 percentage points among Latinx participants. This is in contrast to minimal change as seen on the slide among white participants, which was 3%. So why did telehealth use decrease for older New Yorkers of color? Let's try to figure it out. These are descriptive analyses, and I think help lead us towards a more complex analysis. We found that differences in the way that telehealth is accessed by race and ethnicity. The pie chart on the left of the slide indicates telehealth access by mode overall. The chart on the right shows that Black and Latinx participants are rarely using video-only telehealth. Most of them are using a phone, in comparison to only 30% of white participants who are doing phone telehealth. So the mode of telehealth is differing by race and ethnicity among older New Yorkers. So we also asked those who hadn't used telehealth in the past 3 months why they hadn't. Overall numbers are on the slide, and we see that requiring in-person care was notable for Black participants and less so for participants of other races and ethnicities. So it seems like medical need is differing by race and ethnicity. So we've kind of concluded that both need for in-person medical assistance, as shown on this slide, and mode of telehealth differ by race and ethnicity. Black, Latinx, and participants of another race are mainly accessing health through phone calls, whereas 70% of white participants' telehealth usage had a video component. Furthermore, people of color required more in-person care than white participants, limiting their ability to use telehealth. So understanding these inequities in telehealth could help, reduce the difference in type and frequency of telehealth use. And we're going to continue our analyses here. We now move to mental health outcomes, where we see social determinants of health, such as race and ethnicity and income, really driving differences. So overall, 20% of participants screened positive for depression, 19% for anxiety, and 6% were lonely. Latinx participants were particularly affected. 29% screened positive for anxiety, 28% for depression, and almost half reported being lonely. 22% of participants of another race screened for anxiety, 30% for depression, and Black participants were also over 20% for depression, anxiety, 25% for anxiety, 21% for depression. So we wanted to look at change over time in depression and anxiety by race and ethnicity. The percentage of white participants who screened positive for depression and anxiety decreased slightly between round 1 and round 2, whereas depression and anxiety increased among Black and participants of another race. Depression decreased among Latinx just slightly, but anxiety increased by 8%. In summary, the mental health of older adults hasn't gotten better as the pandemic nears year 3. One of the clearest correlations with mental health was income. Reports of depression and anxiety were highest among those who made less than $25,000 annually, compared to those who made more than $100,000 annually. All to say, income is a clear social determinant of health among older New Yorkers. Finally, we see that depression is twice as high for those with limited mobility compared to those with somewhat limited mobility. This is going back to the question we asked that I read earlier about how much their mobility was limited. Almost 10 times higher, depression was almost 10 times higher among those with very limited mobility compared to those with no limitations. That trend continues for anxiety, but differences are less profound for loneliness. Conversely, resilience is higher among those with less mobility. As you can see, there's less low resilience among those whose mobility is limited a lot compared to those who have no limitation of daily activities. So now we'll discuss social support. We asked participants a question about what services they would like help with, and we noticed that white participants generally reported less need for assistance than participants of other races and ethnicities. So we graphed the percentage point difference between Black, Latinx, and participants of another race compared to white participants. So the biggest gap between white participants and other racial groups was need for food, with Black participants needing plus 18 percentage points compared to white participants, Latinx needing 9% more, Latinx participants needing help with food, and participants of another race having 21 percentage point more need than white participants. The categories where differences were less profound were medical care, applying for public benefits, and employment. And more white participants reported need for debt, loan, or credit card payment compared to Latinx and those of another race. We asked older Asian adults in the past 3 months, please tell me all of the people or programs from which you have received mental, physical, or social support. Physical support would include things like transportation and assistance with household tasks, and we found that family is the most frequent source of support, followed by spouse or partner, friends, neighbors, government programs. So older adult centers I'd like to discuss now as we're going through social support. Older adult centers provide a variety of supports for older adults, but have not been utilized at their rates seen before March 2020. We found 28% of participants reported using senior centers before the pandemic. And among those who visited older adult centers before the pandemic, 41% have gone back, specifically 31% of Latinx, 39% of white and Black participants, and 63% of participants of another race. So this brings us to our conclusions. And the first point on our slide, that social determinants of health continue to drive key outcomes, is not surprising or particularly groundbreaking, but needs to continue to be stated. So when we're thinking about addressing barriers, we can address the relevant structures. We, of course, know race is a social determinant of health, and was, a clear impact on participants' well-being and experience of COVID-19. We also saw that participants are slowly going back to older adult centers and are not socializing as much. And I think, we'd be interested to find out more about who and why older adults are re-engaging and what that looks like for them. And again, mobility, these results by mobility and the questions we asked, I think are really telling. Mobility had a profound effect on mental health outcomes. As mobility declined, poor mental health outcomes increased. So we're seeing that as a particularly vulnerable group. We also noted that differences in health outcomes among older Asian adults tended to be between the sexes, male and females, males having slightly worse outcomes than females, and by immigrant status, those born in other countries having slightly worse outcomes than those born in the US. So these are exciting conclusions that I'm looking forward to digging into more with my colleagues. And we're also, of course, thinking about where we can go to continue to inform policy for older adults. So again, the telehealth results I think are interesting, and we can continue to probe and find out why people are and aren't using telehealth, considering the impact of mobility on well-being, understanding more about in-home services, which I hope Dr. Rosen will speak about, would be a great way for us to understand how we are reaching those who have limited mobility and are among the most vulnerable. We did ask participants, and we didn't share it in this presentation, but we did note that, most participants, 84% reported knowing where to get accurate, timely information about COVID, but a third still encountered COVID information they were unsure about. So I'd really like to find out more about what these sources are, and even though they trust the sources, why they're still coming across information that's unsure. And as I mentioned before, there are drivers of social re-engagement, and we'd like to see what those look like and kind of what that trickle back to normalcy and back and forth looks like. So I'd like to acknowledge those who participated in this study. It takes a lot of time and labor to share your information and help create data. Thank you to the comms team for, of course, helping this presentation, and my colleagues, as well as our funder, New York Community Trust. And, we rely on our study advisory group to help continue to create useful data and results. We'll now turn to the panel discussion, and I think I can keep sharing my slide as Wafa. I will let Hugh share the slides as we introduce. Thank you.
Well, thank you very much, Abba, for sharing with us the very interesting and informative findings from the second round of the Silver survey. I'm now going to invite all of our panelists to please join us by turning on your video, if possible. Thank you. And I'm going to start by briefly introducing our panelists, and then we'll get into a panel discussion. I want to invite everyone who is joined us today to please submit your questions through the Q&A box, and we will get to your questions after the introductions and the beginning of this conversation. So let me start by introducing Isabel Cheng, and Isabel is the Executive Director at Hamilton Madison House, which is a nonprofit settlement house established in 1898 to provide a safe home for New Yorkers citywide to thrive, with main program sites located in Chinatown, Lower East Side, and Two Bridges neighborhoods. She's been with the organization for 25 years and providing both direct services as well as contributing to the evolving mission of the institution and the commitment to serving the most vulnerable populations, including older individuals, children, new immigrants, refugees, and the underemployed. I'm going to move on next to introduce Jocelyn Groden. Welcome. And Jocelyn is the Associate Commissioner of the Bureau of Social, Direct, Mental Health, and Elder Justice Services of New York City Department of the Aging. And she oversees programs and contracted services that work to improve the quality of lives of older adults in the community, including case management, home care, caregiver employment, intergenerational issues, elder abuse, and crime victim services. She has more than 20 years of experience in New York City government and has focused her career on advancing social justice with a focus on gerontology, homelessness, mental health, and many other topics of critical importance to New Yorkers. Let's move on to our next panelist, and that's Jennifer Rosen. Welcome. And Jennifer Rosen is the Director of Epidemiology and Surveillance for the Bureau of Immunization at New York City Department of Health and Mental Hygiene. And in this role, she oversees and guides surveillance, epidemiologic analyses, and leads investigations of outbreaks of vaccine preventable diseases. And is also, as part of the COVID-19 response, she served as a principal scientific advisor and director of the Vaccine Confidence Branch. Thank you for joining us. And next, I'll present Megan Shinneman. And Megan is a senior director of program development and healthcare innovation, New York City Department of the Aging. And she coordinates the development of the department's solicitations and other innovative pilots and partnerships and initiatives for older adults. And she has more than 15 years of experience in public, nonprofit, health, and aging sectors. She also has been and served as an independent consultant as well, and a policy analyst for United Hospital Fund. So, and next, our last but not least of our panelists is Catherine Thurston. Welcome. And Catherine is the Chief Program Officer of Services Program for Older People, SPOP. And in this role, she oversees SPOP's Article 31 licensed mental health clinic and its multiple satellites, and is very engaged in efforts regarding recovery, bereavement support, community outreach, and other program initiatives. So thank you all for joining us today. And obviously, Abba will also join us in this conversation. And I'm going to start with a couple of questions and then take on some of the questions from the attendees today. And maybe I'll start with going to you, Jocelyn, and just for you to give us a sense. Obviously, COVID-19 was an enormous, had enormous impact on your constituency of older adults in New York. And you know what? At this point in the pandemic, 2.5 years later, what are the things, the best practices, what are the lessons that you've learned in terms of implementation of programming during this crisis, and the ones that you would very much advocate for retaining as we move forward?
Thank you so much, Wafa, and thank you so much to the leadership and this study to look at these really important issues and how the pandemic and social isolation has impacted our older adults while we focus on keeping them safe. So a number of things. During the pandemic, I'm so proud of DFDA and the city of New York that we were able to keep all of our services going and move everything to a virtual or telephonic modality, including converting our congregate meals to a home delivered model. So there was never any disruption of service. So I think coupled with that is really important lessons around adaptation and need to address the digital divide. So some of the things we did that are really important and we continue to talk about and expand is bringing tech and tech education and affordable connectivity to older adults. So one of the things we did during the pandemic is distribute over 20,000 tablets to bring older adult center activities, to bring programs that address social connection to people at home. So including geriatric mental health, and we have a number of practitioners on this call who are experts in that area. So we need to continue there and continue to make this vehicle accessible to older adults. We also birthed some new programs during the pandemic. One of them is Friendly Voices, which is a modification on our Friendly Visiting program, which pairs a trained volunteer with an older adult. We continue to do those programs virtually and telephonically while we have an in-person model. So I think one of the things we've learned is the importance of choice. personally. I think nothing, when you talk about social isolation, nothing is as powerful as an in-person interaction. That said, people are still afraid. And then there's things like intermittent weather, illness, and so on, to get these services to the homebound. So we need to continue to address the digital divide, get the education. We also did some really interesting intergenerational work, such as partnering young people with older adults to do what we called New York stories, where older adults told their stories. They were documented in beautiful booklets and provided to the older adults. So these are programs we continue, again, looking at hybrid services. I know a lot of our senior centers, which we call older adult centers now, are continuing to provide a yoga class, for example, where you could come to the center directly or opt in virtually. So I think those are some of the examples. We also have a mental health program, PAX HB, which focuses on bringing mental health to the homebound and to come together as one city to deliver services.
Well, thank you very much. And clearly several of these are good to keep as we move forward and offer the opportunity to broaden the reach, as you said, while obviously optimally is the in-person interaction, but nonetheless you can reach many more probably through these new innovations. Moving to you, Jennifer. I'm just curious in terms of, obviously we appreciate the importance of vaccination, particularly for older individuals. And maybe you can give us an update on where we're at now in reaching this population in our city, and what are the current recommendations, and how can we optimize, of course, the uptake of the bivalent booster, which is currently available?
Sure. Well, thanks for that. In New York City, the majority of adults aged 65 years and older have received at least one dose of the primary vaccine series. So it's about 90%, which is great news. And about 85% have completed the primary vaccine series, so very high. But when it comes to receiving an additional dose, which would include a booster dose, only 60% of adults in this age group have received an additional dose, and that's something, an issue that we've seen across age groups. And now there's a new bivalent booster vaccine, which we're really excited about. This is a vaccine that includes the original strain of the virus that causes COVID, but also contains a strain that protects against the Omicron variant, which, as everyone knows, has caused the majority of disease over the past year and is still circulating widely. And so this bivalent booster vaccine was developed to increase protection against both. So this is newly available. It's widely available now. There are options for Pfizer and Moderna, and it's recommended that everybody age 5 years and older get this bivalent booster vaccine as long as it's been at least 2 months since your last vaccination. It doesn't matter if your last vaccination was Moderna or Pfizer, you could get either. And it doesn't matter if your last vaccination was a primary vaccine, your primary vaccine series or your booster. So we're really trying to promote that widely. And it's particularly important in this age group where risk of serious complications is high.
Yeah, and I think maybe another, I was thinking that since older individuals were really at the front of the line way back in early 2021 in getting vaccinated, so they've been vaccinated a long time ago. So, and we know that protection wanes over time. So that third and fourth doses of boosters are profoundly important for this population, as you indicated.
Yeah, that's exactly right. And just to put in another plug for the flu vaccine, I think the data that was presented was so helpful, and getting flu vaccine is equally incredibly important in this age group for preventing serious complications, hospitalization and death due to influenza.
That's true. Thank you. I'll move on to Isabel, and we saw from the data that Alba shared, which is quite interesting, that a very large percent, more than 70% of the age and older adults who participated in the survey reported that family was the key source of support. And in terms of your work and how can we leverage that strength in terms of programming for this population of older New Yorkers?
No, thank you for the question, Rafa. Hamilton Madison House runs one of the citywide DFTA-funded caregiver program, and if you look at the history and trends in the Asian community, Chinatown is only so big. And if you look in the 70s and 80s, most families moved out of Chinatown because of historical gangsters and children having to leave Manhattan Chinatowns and moving out to the outer boroughs. So when that happened, there were the whole concept about purchasing multi-generational families, having multi-generational, like 2 to 3 families, so that the family members can live together while in the meantime supporting each other. So this whole concept of economics, because one, most of these families were immigrants who needed the grandparents to take care of their grandchildren, and mothers and fathers would have to work, and sometimes out of the city, out of Manhattan, and have to go out of state. So they have this whole new phenomenon of grandparents taking care of raising grandchildren. But also the whole pandemic really spurred, I think, this whole anti-Asian rhetoric, hate. And so a lot of the children had to step up and do most of the support for their parents. Obviously, the whole fact that Asian seniors were mostly the targets of these anti-Asian hate crimes. And we see that children having to be the providers, the the brokers, translation, but the persons to deliver groceries and help these individual families. So it's not surprising that this was happening during the pandemic. And I believe that, having that kind of support was able to have these families provide those additional, like having to go to pantries, getting vaccinations, because most things, if you look at, is over in English, and it's very hard for a family or a senior who doesn't speak English or read for English to have that capacity to open a package of home test kit and do the test kit at home. So a lot of it is really about language, having that kind of information, and the children having to be the broker to do the translation for these family members.
Thank you. And it's quite interesting, and I think we often see that with other migrants as well, where the children often are the link to the larger society overall. And Catherine, I'm wondering, in terms of your work at SPOP, and as you know, that the findings from the survey still continue to show that rates of depression, anxiety remain higher than prior to the pandemic. So the question is, what can be done in order to respond to some of these mental health challenges that this population continues to face?
Thank you for the question, Wafa. So, it's not a surprise, certainly to us at SPOP, and it shouldn't be to anyone on this panel, that the rates of depression and anxiety and loneliness did not go down in the second part of the study, because for many of the older adults in New York City, certainly those that we treat at SPOP, the pandemic is not over. They have not resumed life as it was before, the way other cohorts might say that they have. And they continue to require interventions, mental health interventions, that luckily for us, and one of the silver linings of COVID, is that the city really came together in some extraordinary ways to create new telehealth interventions for behavioral health for older adults. The problem is there's not enough of them. And, as you say, Wafa, that this is the rates are not going down. We don't think they're going to go down anytime soon. And the stigma around mental health for older adults seems to have lessened somewhat as well, since mental health has become so much a part of our national dialogue since the pandemic began. And reaching out for help is less stigmatized. And as a result, there are more people reaching out for help, which is a good thing. But then our challenge on the systemic side, because SPOP is a relatively small to mid-sized organization, we remain to date the only organization in New York City that's solely directed at older adults and behavioral health. While a lot of people are engaged in the work, Isabel's programs do wonderful things for older adults. Hamilton-Madison House treats across the lifespan. There needs to be real support given to all the programs out there in New York City that provide behavioral health to become more competent in treating older adults. And at the same time, our aging service providers need help in becoming more fluent and competent in serving people with behavioral health challenges, because one program is not going to be enough to meet the need. And we all need to become, I think, well-versed in how we can treat older adults with behavioral health issues there should be no wrong door in New York City. And we certainly have done some great work with the New York City Department for the Aging to make sure that many older adult centers now have behavioral health programs embedded within them, but it's not nearly enough.
And thank you. And maybe building on this response, and this is a question for you, Megan, is we saw from the survey that certainly there were challenges in terms of mental health, depression, anxiety, loneliness, but also as well concrete needs and the need for specific resources. I'm wondering whether you can share with us some of what you have done and your organization has done to meet some of those needs.
Yeah, thank you, Wafa, and thanks for having us. And it's been interesting to hear all of our colleagues here talk about the issues that our older adults have been dealing with for the past 2+ years now. We actually here at the Department for Aging started a pilot with a health funder, Health First Medicare Advantage plan in the height of the pandemic, which was an interesting time to start, but it was an insurer that was really interested on reaching those very isolated, hard to reach older adult population that was probably the most isolated during this time period. And the main goal was to set up a system where we could reach individuals, get them reconnected to primary care, but also understand that, people that weren't going to their physicians might have additional social needs that needed to address first. And so this program has kind of exploded, not surprisingly, because, the DFTA's current reach before the pandemic was about 240,000 older adults. And, there's 1.7 million older adults here in New York City. So we realized there was a large population that we weren't reaching. We did a good job, but there's a lot of needs out there in underserved populations. So we had, we're constantly growing this pilot program, but we have a lot of our CBOs that we work with, some here, that were reaching out to these older adults to better understand their needs and navigate to the services that we offer. And we saw that there was a huge increase, not just in some of the services and needs that we discussed here, social isolation, socialization needs, mental health needs. Obviously, those are the first that come to mind. Not surprisingly, we saw a huge demand for food. Older adults stopped coming to the centers, and we went, transitioned to a grab and go and home delivered meal emergency delivery in that process. And we've slowly started to see those numbers come back. We're actually at 40% of our congregate meal delivery pre-pandemic. We were about 40% level, but the older adults are actually coming back to the senior centers, older adult centers. Jocelyn corrected us earlier. We're still getting used to the term. And that now is actually up to almost 80% of the pre-pandemic level. So we are seeing the older adults coming back, but we're understanding that the older adults, we need to be more flexible in the delivery of our services as well, right? Because not everyone is going to come back. So the hybrid that we were talking about, transportation was another, not surprisingly, huge issue that we've been hearing quite a bit about. We obviously decreased the demand for group transportation, but saw the need for individual transportation skyrocket. So that's something that we're looking at about how we can get better access to the older adults that are asking for some of these needs. It was interesting to hear your telehealth comment. That was something also through our Health First relationship and pilot. We actually were informing some of our older adults members that we were interacting with that telehealth was an available service. Many of them weren't aware that they could have telehealth or even in-home doctor visits. And so that's something that once they knew that that was a benefit that was being offered, a lot of older adults and their families really jumped on and were trying to get connected to. So those were some of the immediate things. And then of course, housing, which is I think a longer term discussion and topic for a whole nother webinar. But those are some of the things that we're seeing. And I saw a few of the questions. I don't know, Wafa, if you're going to transition into those, but I do know that as well as some of these other pilots that Jocelyn and I were mentioning that, were implemented in the height of the pandemic, just before we all really transitioned at the beginning of the pandemic, DIFTA opened our No Wrong Door Aging Connect, which is 212 Aging New York. And we kind of see that and encourage all older adults and family caregivers to access that phone number as a way to kind of access all of our services. We see that as our initial No Wrong Door. And so in terms of outreach, we've really been pushing that and encouraging people to contact that to access most of our DIFTA services. So I'll stop there. I'm sure you have additional questions here.
Thank you. And it's really interesting to hear of all the wide array of services that all of you offer and to older New Yorkers. It's really quite heartening. While we know there's a lot more that's needed, obviously. Maybe I'll go to you, Abba, and there's several questions that are in the that were submitted. I think maybe a quick one is number of participants, respondents in the survey, and also household size, questions about household size and some definitions, maybe definition of resilience. Yeah, go ahead.
Yeah, thanks, Wafa. We had almost 300 participants from round one continue into round two, which we were very happy with. We put in, and our colleagues put in a lot of effort to get a hold of our round one participants. And then we added 64 older Asian adults. So we were able to get a great sample size for this second round. To measure depression, anxiety, we used PHQ-2 and GAD-2, and then resilience, we used what is the brief resilience scale. And then finally, just to note, loneliness was just a self-reported measure. We asked over the past 2 weeks, how lonely were you? Answers ranging from not lonely at all to extremely lonely.
Thank you. And maybe you can touch on another question is, what about access to other resources in the community? The interesting question about access to park and green spaces and so on.
Yeah, I saw that. That's a good question. We did not ask about access to parks or green spaces. I think that'd be a great question for us to ask, especially given the variety of responses and how much people are getting out of the home to socialize. And then I also wanted to note, we did ask about household size, and we did a fair amount of analysis around that from our round one results. And we'll definitely take a look at that as we continue analyses with the second round of data.
That's great. Thank you. I'm going to also take another question that we got from the audience, and the question is about the older adult centers, and a question about, are they open? Are they all back in service? What's happening with those vital community resources?
I can jump in, and then I'm sure my colleagues, many of you can answer this as well. So all of our older adult centers are open. DIFTA funded older adult centers are open. As I mentioned, we are seeing only an 80% of attendance compared to pre-pandemic levels. And, we just did a quick run that of those, 80% of the people that have returned, 80% of the pandemic levels, about 77% of that are people that were previous centers. We haven't done an analysis of who the makeup and the cohort, so that's something that we probably should look at and better understand exactly who is returning, but they are all open. And I know I neglected to mention this, but also during the pandemic, we had a solicitation to renew our contracts with many of our centers. So we actually increased increased the number of centers that are now available and open to the city. We went from 249 to now 272. So no plans to close them that I'm aware of. We just opened them, and I would hope that we're really making an effort to get our numbers and older adults back out there. We just released a campaign to let people know that we're open and really encourage older adults, to access the services that these centers are offering, whether in person or hybrid, and in a safe manner. So they're definitely open, and we're encouraging, older adults to go out.
Thank you. And maybe going back to you, Jennifer, in terms of talking about taking services to the people, maybe you can talk a bit about some of the department's efforts to try to reach people in the home with services, including vaccination and so on.
Sure. A really important service that would be very important to increase awareness about is the ability to get in-home vaccination, which is available to people who are either homebound or who are age 65 years and older. And to access this, people can make an appointment online at the Department of Health's website. There's a COVID vaccination site, but people can also call, and the phone number is 877-VAX, VAX 4 NYC. So people who don't have internet or aren't as internet savvy can call that phone number to make an appointment as well.
That's fantastic. That's really great to hear. A broad question is how is information about the availability of this wide array of services to the community? How is this information disseminated? How do you try to reach the people who need to be reached? What are some of the communication methods that you are using to reach the older New Yorkers? Anyone can answer this one.
I can start with the Department of Health. We have developed extensive relationships with community-based organizations over the course of the pandemic. And so we have really focused on sharing information with partners, trusted messengers and partners from within the community. That way they can share the information with people directly, as serving as a trusted source of information. That's separate from all of the media, which is obviously very important, but we think working from within the community is an important priority.
Other comments or inputs? I was particularly struck by the very high rates of reporting amongst Latinx, older New Yorkers, the very high rates of loneliness reported by Latinx New Yorkers in particular, and maybe specific efforts to reach that population that you're aware of. Go ahead.
Just wanted to chime in about outreach to the communities. I think most essentially it's important that, caregivers have that information, but to a mainstream community. But most importantly, it's having the language, everything being translated, and that's really key. And I think having seniors coming back to the senior centers, because that's where older adult centers, that's where they get most of their information from, right? This is where they get it from the social workers, the caseworkers. There's this is so intricate in terms of having information and linking them to our communities. I think we've learned from past like Hurricane Sandy and all these other incidents, natural disasters, that these are things, if communities are, have an established connection to an organization, there's definitely easier ways of getting or responding to a catastrophe faster, because there is this already a connection there, a linkage made already prior to the incident.
That's great. And we always say it's preparedness is fundamental, as well as, of course, response and recovery, but being prepared is very critical. And I know we've run out of time. Maybe I'll go back to you, Abba, and just to share with us what are next steps, further analyses that you're planning to do with the data.
Thanks, Wafa. We're really looking forward to releasing a summary of our results. A lot of what was shared today will come forth in a couple-page document in the next few weeks, so please keep an eye out for that. And we'll continue to build our analyses on round 2. And, I think really what is interesting to me for a future round of data collection is this re-engagement. Who is re-engaging at what time? times, what is driving that motivation? It sounds like that type of information will be helpful as we're looking to get, see older adults re-engaged and focusing on preparedness.
Well, thank you very much. I want to end by thanking Abba and the team, of course, for conducting the survey and sharing these key findings from the survey. There's a lot more data there, and I'm sure there'll be a lot of opportunities for sharing more of the data that will emanate from this survey. I want to thank all our panelists for their contributions to this important effort in our community, and also to thank them for their contributions to the discussion today. As you can see here now on the screen, the recording and the slides of this webinar will be posted on our website, so stay tuned to that. And I think there's another slide to follow that describes our next ICAP Grand Rounds. Please join us. This is going to be an interesting discussion on really groundbreaking work on an injectable long-acting pre-exposure prophylaxis PrEP for HIV prevention to be given every 2 months by injection. And this will be a presentation by Dr. Rafi Landowitz from UCLA Center for Clinical AIDS Research and Education. And please put this date on your calendars. It's on Tuesday, November 15th at 9 a.m. Eastern. Thank you all very much for joining us today, and have a good day.